I am Dr. Benjamin Levy. I'm a thoracic medical oncologist at Johns Hopkins School of Medicine, and maybe we can just go around the room and introduce one another.
My name is Dr. Wally Kern. I'm a radiation oncologist. I'm the Chief Medical Officer for Genesis Care, and I'm also Professor Emeritus at Emory University.
Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Radiology and Vice Chair for Education at Memorial Sloan Kettering Cancer Center. And I'm also a Professor of Radiology at Weill Cornell Medical College.
Mike Lanuti. I'm a thoracic surgeon at Massachusetts General Hospital in Boston. I'm the Director of Thoracic Oncology for our Division of Thoracic Surgery. Also have an adjunct associate professor at Harvard Medical School.
I'm Ramaswamy Govindan, a medical oncologist with interest in lung cancer. I'm a professor of medicine at Washington University.
This is a 91-year young Pakistani male with no smoking history, diagnosed with stage 4 adenosquamous of the left upper lobe with bone metastases. The PD-L1 is greater than 1%. I don't know if we'll get more of a cutoff than that. No previous or current treatment. What are the recommendations for treatment and next generation sequencing? So again, 91-year-old patient, never smoker. Patient presents with a cough, weight loss, and appetite changes. The performance status is 2. Patient has no past medical history, no, in terms of social history, no history of tobacco, alcohol, or drug use, has a history of military service, family history, no lung cancer history, or no real significant family history as it relates to cancers. Patient, we don't have imaging here. Patient has a CT of the chest that reveals a left upper lobe mass, 4.8 by 4.3 by 5.5. Multiple soft tissue left lung lesions and lytic lesions in the dorsal vertebrae. A core biopsy reveals a left upper lobe, a core biopsy of the left upper lobe mass is consistent with adenosquamous, positive for TTF1 and P40, 2 markers for adeno and squamous respectively. The molecular testing is done, and we've got an ALK negative. We have that. I don't know if it was an IHC or FISH. The EGFR was not done due to insufficient sample size, and the PD-L1 is 2%. So pretty specific on that PD-L1. So Dr. Govindan, this will go back to you here. We've got a 90-year-old male, never smoker with imaging finding of advanced stage lung cancer, a biopsy adenosquamous with insufficient molecular testing. How do you approach these patients? Clearly, the diagnostic algorithm has changed over the past 5 to 10 years. What do you do in your clinic in these cases?
So given the fact that he has bony metastasis, granted not as extensive as sometimes we see, I would start off with cell-free DNA and before subjecting a 90-year-old man to another biopsy. If the cell-free DNA shows EGFR mutation, which is what you probably would expect in this population, I think I would stop there and I would direct therapy based on that. If the cell-free DNA shows DNMT3, a mutation that likely is coming from an aged bone marrow, clearly you don't have an answer for the lung lesion, what is driving the lung tumor. I would try to get a biopsy if possible. The lesion, the thoracic lesion, the T2 lesion may be amenable given the nature of the description, going by the description. If not, the lung lesion may be amenable for a biopsy. I would try to get that. And there is a higher prevalence, as we have discussed before, in never smokers and people from the Asian, although there is a lot more from the Pacific Rim Asian countries than East Asian or Southeast Asian countries. I would still consider looking for an actionable mutation, i.e. EGFR mutation, one way or the other. If this patient happens to be in a place where the resource and the availability of testing is not an issue, doing a next generation sequencing would be a great thing to do because in one go you'll get the panel of testing, including fusions as well as point mutations. But if it is if the patient is from a place where your options are limited, then looking for drugs that are available would make more sense. Here in this instance, approved drugs are targeting EGFR and ALK in most countries, so I would look for those things rather than looking for the entire panel of genes.
You highlighted one of my favorite points about liquid biopsies, this DNMT mutation or CHIP. Can you just briefly, for our teaching, because the patient's 90, you're doing a liquid biopsy, you're going potentially to see other mutations that aren't relevant from or aren't from the cancer. Can you just briefly discuss that?
Sure. It was first recognized, I would say very proudly, by my colleague Tim Lay at Washington University in the very first unleading, when one of the earliest studies showing that there are mutations that are present in patients with leukemia on healthy individuals. Bone marrow samples showed the mutations that are typically seen in patients with leukemia. We called it ARCH mutations for clonal hematopoiesis, keeping St. Louis in mind. But then subsequent studies from Boston and others showed that these are clonal hematopoiesis of indeterminate potential. So that's the CHIP mutations have been described. And I think the mutations to watch for are P53 mutations, JAK2 mutations, and DNMT3A mutations, and others that are typically seen in this bone marrow. And I think one mutation that I do feel that sometimes people get a little thrown off is when somebody with lung cancer has a JAK2 mutation in the bloodstream, well-known V671F, then there is a concern that, oh, this is what's driving the lung cancer. In reality, that's probably coming from the bone marrow. But then EGFR mutations are very uncommon in the bone marrow, so ALK fusions are uncommon too, or I should say they're not seen there. And so then that's not an issue. And increasingly, I think people are getting better in eliminating them. But it is a fact that healthy individuals harbor potentially pathogenic mutations, and showing once again that these single mutations alone don't cause cancer, and other events have to happen to turn this into a disease process. So we do find mutations arising from bone marrows or bone marrow precursors in a seemingly healthy population.
If a clinically relevant question here, if you do identify a mutation in cell-free DNA, do you wait to confirm it in the tissue, or do you just move ahead with a targeted agent?
Yeah, we move ahead. It's been repeatedly shown that EGFR mutations, whether they are found in the tissue or in the cell-free DNA, they show the same response rates. And so it is not a false positive test. So I think there's no reason to repeat another test. Mutations that are known to happen in the lung cancer tissues, if you see in the peripheral blood, they are real.
Great. Okay. Great discussion on NGS and liquid biopsies.